you this morning. So this second half is going to be tackling three parts, talking about rarer types of glaucoma, medical treatment, including laser, and surgery, as well as complications. Now, just to make sure that you're all interacting, we just want you to answer this question, which is an easy question, and there's only one correct answer to this, so you know it's easy for that reason. So, which is the best team in the English Premier League? Okay, there's only one correct answer. So, and if you get the answer wrong, you won't be allowed back next year. So, it's in your interest. Oh, someone's got the wrong answer. Someone won't be coming back. Okay. Okay, you can vote now. Okay, so the correct answer is, of course, Liverpool, who won 2-1 yesterday and still in the championship race. Okay, so let's start talking about rarer forms of glaucoma. So this is a question. Have a look at the pictures. These are two eyes of the same patient. Okay, the bottom picture is normal. The top picture is showing an abnormality. So what feature is indicated here? Okay, so if you cast your votes. Okay, so we had a good vote, 24 people voted. Okay, most people think the answer's A. And that's correct. This is a picture of angle recession shown by widening of the ciliary body band. So just to talk a bit about angle recession, it usually follows blunt trauma, and there's a cleavage between the circular and longitudinal muscles of the ciliary muscle, and you see a widening of the ciliary body band clinically, and sometimes it's quite subtle, and the only way you'll spot it is if you compare it to the other eye. Usually this blunt trauma will be associated with high femur, and eyes that have high femur have a higher incidence of angle recession. How much angle recession is significant? Well, if you have more than 180 degrees, some studies have shown that if you have more than 180 degrees, that significantly increases the risk of angle recession. Now, interestingly, if you have angle recession in one eye, you have an increased risk of glaucoma in the other eye. Yeah, so basically it could be that these eyes that develop glaucoma have an increased risk anyway for some other reason, and that's why they develop glaucoma. And the treatment of angle recession is similar to open angle glaucoma in terms of the medical treatment and surgery. Okay, so next question is about steroid-induced glaucoma. So which of the following are risk factors for steroid-induced glaucoma. Family history of glaucoma, hypermetropia, older age, angle closure, or thyroid eye disease. There's only one correct answer. So most people have voted for A, and A is the correct answer. Okay, so steroid-induced glaucoma is a rise in IOP by steroids given by any route. So it can be topical steroids, intraocular, or intravitreal. And intravitreal is a potent way to rise the intraocular pressure, particularly with the new steroid implants that last for a few months, and there's a high risk of secondary glaucoma. It's a secondary open angle type of glaucoma. The risk factors, as pointed out by several studies, are high myopia. Younger age, young people tend to have are the ones who get steroid response, not older people. Type 1 diabetes. Now, it could be type 1 diabetics are more frequently seen in hospital, and that's why their pressure is checked more frequently, so this could be a kind of confounding effect. And patients with open angle glaucoma and their first degree relatives, so brothers, sisters, parents, and so on, they're at increased risk of steroid-induced glaucoma. Why does it happen? Well, there's certain changes in the trabecular meshwork cells. The trabecular meshwork cells change morphology with prolonged steroid use, and also the trabecular meshwork cells are responsible for phagocytosis of material away from the eye. So if you've got reduced phagocytosis, then that will tend to increase the pressure as well. The management, number one, if you're asked about management, withdraw the steroid treatment. Okay, so stop whatever steroids have caused the problem in the first place. Now, sometimes usually the pressure will go back down, but sometimes it won't. If it's been prolonged use of steroids and there are irreversible changes in the trabecular meshwork, then the pressure can be elevated even though the patient has stopped steroids. One option is to use steroid-sparing agents. So if you've got a uveitic patient who's on steroids and they're well controlled, then you can consider steroid-sparing agents. You could, uveitic doctors give steroid-sparing agents, cyclosporin and so on, or give non-steroidal agents which won't rise the pressure. And then the treatment for secondary open angle glaucoma is similar to primary open angle glaucoma in terms of medication, and trabeculectomy or tube and SLT are all reasonable options for steroid-induced open angle glaucoma. Okay, so I want you to have a look at this picture for me. Okay. Okay, so have a look at the picture and tell me which treatment would be the best initial treatment for this condition. Okay, so we have 20 votes, a few people abstaining. Between A and C. Okay, and the correct answer is PI. So this picture of plateau iris, as shown by the flat iris configuration. And in fact, a lot of the other treatments are reasonable, but not as an initial treatment. So plateau iris can present incidentally. You can see patients in casualty, they have no symptoms, and you just happen to pick up that they've got a narrow angle on gonioscopy. The hallmark of the condition is that they tend to have a normal depth of anterior chamber, but they have a occludable angle on gonioscopy. The other way they can present is as an attack of angle closure or with high pressure. And like I said, the hallmark of the condition is to have a narrow angle in the presence of a normal depth AC. and that's sometimes termed angle crowding. This is a key term. And you can see here the picture that shows the classic double hump sign that we see on gonioscopy. And the iris is flat, as you saw in the earlier picture, and it's inserted anteriorly into the ciliary body. Imaging can be useful to exclude iris or ciliary body pathology if you're not sure of the diagnosis. The first line treatment is still a PI. Whenever you see an occluded angle, the first line treatment is still peripheral iridotomy, and these patients may still have a reversible element of pupil block. So if you do a PI, it can still be helpful. Sometimes you can use pilocarpine as a temporary measure, but it's not a definitive treatment. And the definitive treatment is argon laser iridoplasty or lens extraction. So if you've got a patient who has a clear lens and good visual acuity, then you might be tempted to offer them argon laser iridoplasty if the angle is still closed after PI. But if they have a degree of cataract, then you can offer them lens extraction. Okay, so next question. Have a look at this picture. You can see the abnormality. Which of the following is true with regard to this condition? Okay, looks like fairly unanimous here. So the correct answer is E. Glaucoma associated with Sturge-Weber often responds poorly to medical treatment and often needs surgical treatment. So a bit about Sturge-Weber syndrome. It's a congenital abnormality where you get a facial malformation and other malformations in the body associated with ocular and vascular abnormality on the same side. You can get various neurological abnormalities. Various neurological abnormalities and systemic abnormalities, as well as eye problems. The most common ophthalmic manifestations are dilated episcleral vessels, and glaucoma occurs in about 70% or less of children. What's the cause of glaucoma? Well, they have an angle abnormality, and also their episcleral venous pressure tends to be high. And the treatment of the glaucoma associated with Sturge-Weber is with aqueous suppressants primarily. Miotics can be useful. The most important point about surgery in these children is any sudden decompression of the eye is likely to lead to a choroidal hemorrhage and then increased risk of choroidal hemorrhage. So any surgery that, this is a common question in the exam just for this reason. They want you to appreciate that you should avoid any sudden decompression of the eye. So if you mention, whatever procedure you mention, just to mention also that you're doing it because you want to avoid any sudden decompression or change of the pressure. Some people do the trabeculectomy, but you must make the trabeculectomy flap sutures very tight, not to allow early flow, so the pressure does not drop. Tube is a reasonable option, a ligated tube. Sometimes we ligate the tube with Vicryl, so that the Vicryl will open after a few weeks and the pressure reduction is gradual. And in eyes with poor visual prognosis, CPC is a reasonable option as well. So you can see eye with aniridia here. And it's giving you a list of features, which is the most likely feature associated with aniridia. So there might be more than one, but which one is the most likely? Okay, so we have mostly C's and a few D's. Sorry. Okay, so the correct answer is foveal hyperplasia. So you can see in this picture there's an absence of iris, and you can see the cornea, there's some keratopathy here as well, and that's quite classic of aniridia. The most important ophthalmic features are reduced visual acuity, secondary to foveal hyperplasia, and the corneal abnormalities that they get. So aniridia is a congenital absence or hyperplasia of the iris. Some children don't have a complete absence, they have a rudimentary iris dump, and it's due to a dominantly inherited gene PAX6, which I'm sure you've heard of. The associations are many, but the most important ones are reduced visual acuity from foveal hyperplasia, nystagmus, glaucoma, and refractive error. About 10% of children can get optic disc coloboma as well, and that's why it's on the list, but it's not very common. So in terms of aniridia, and this is not a popular exam question, but you might be more likely to get this in the written exam. So about a third of cases are isolated, and these are the autosomal dominant types of aniridia. About 2/3 of cases can be associated with this Wagner syndrome, and Wagner stands for Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation. Gillespie syndrome is a rare association, occurs in 2% or less of cases, and Gillespie syndrome is where you have aniridia associated with cerebellar ataxia and mental retardation, and that tends to be autosomal recessive. Glaucoma occurs in about half of eyes with aniridia, and it's due to underdevelopment of the angle and Schlemm's canal. Later in life, the iris tissue tends to cover the trabecular meshwork as well, and that can exacerbate the glaucoma later in life. And there's a link there which is a nice article about management of aniridia-associated glaucoma. We will be giving you handouts later on or tomorrow for both of these talks. The results for trabeculectomy are variable. Trabeculotomy angle procedures is not very successful, but filtering surgery or a tube works quite well. So next question is about Axenfeld-Rieger syndrome. Okay, so which of those options is true about Axenfeld-Rieger syndrome? People are voting for B, and B is the correct answer. And in fact, that's one distinguishing feature between Axenfeld-Rieger and ICE syndrome. ICE tends to be unilateral, whereas Axenfeld-Rieger tends to be bilateral, and they're both associated with glaucoma. So Axenfeld-Rieger is autosomal dominant, not autosomal recessive, and associated with anterior segment dysgenesis as well as systemic abnormalities. The most common features are posterior enviotoxin, which is anterior displaced Schwalbe's line, in addition to iris abnormalities. The systemic features include dental, facial abnormalities. They get pituitary, not hyperpituitary involvement. Glaucoma develops in about half of eyes again, typically autosomal dominant, and is a milder development of the angle. Again, angle procedures tend not to be very successful, and the eyes do usually fairly well with trab or tube. So this question about ICE syndrome. ICE syndrome is quite a rare condition. You can see this eye has a corneal graft and has iris abnormalities. So which of the following has been implicated in the etiology of ICE syndrome? Which of those viruses? Okay, so it's between herpes simplex and rubella, and the correct answer is herpes simplex. So ICE syndrome is a variety of conditions with similar pathogenesis, usually presents in adulthood with iris and sometimes corneal changes depending on the type. The cause isn't really known, but PCR studies in these eyes have isolated herpes simplex and Epstein-Barr virus. Basically, there's abnormal endothelial cells which migrate over the angle and lead to iris contraction, and that's what causes the glaucoma. So in terms of the types of ICE syndrome, they can be classified into three broad categories. There's Chandler syndrome, and you can remember C and C, so Chandler's in C and cornea in C, so that's the one that gives corneal abnormalities. And essential iris atrophy, again, I and I, so iris atrophy gives iris abnormalities, which is correctopia, polychoria, and ectropion uveae. And then the third one is also iris abnormality with some corneal abnormalities. The treatment of ICE syndrome-associated glaucoma is aqueous suppressants primarily, and again, trabeculectomy or glaucoma drainage device. Eyes, especially with Chandler syndrome, often will require corneal graft at some stage. So these can be difficult to manage because they require both glaucoma and corneal surgery. Okay, so we're going to move on to the treatment of glaucoma now. So which of those is true about acetazolamide or Diamox?
D.
correct answer is it can cause transient myopia, and some patients will have a transient change in refraction following oral acetazolamide. Just a reminder that acetazolamide blocks carbonic anhydrase, and that can lead to reduction in intracellular fluid and intraocular pressure. It can be administered orally or IV, but not subcutaneous or intramuscular. The side effects of acetazolamide treatment, most common is fatigue. Paresthesia is very common. Most patients will complain of tingling in hands and feet. And GI upset is the other common one. Rarely it can cause Stevens-Johnson syndrome and blood abnormalities. You shouldn't give acetazolamide to anyone who's allergic to sulfonamide or with renal impairment. So in your exam, if you say, well, I treat this patient with acute angle closure and I'll give them 500 milligrams of Diamox IV, and I would ensure they're not allergic to sulfonamides or have renal impairment, that sounds good. It shows that you're aware of the contraindication to treatment. Sometimes acetazolamide can cause electrolyte abnormalities, and I remember as a resident, there's one patient I had who was pre-op going for surgery, and they had a potassium of 2, and they developed an arrhythmia, and we were in our eye hospital, so we had to blue light them out to the nearest hospital. So just be aware that we have a lot of patients with long-term Diamox use, and they should have their electrolytes checked on a regular basis. It's okay, I'll give you the answer here, so no problem. Okay, so aproclonidine is an alpha-2 agonist, not antagonist. We don't give iopidine, we don't give brimonidine in young children. We can give iopidine, and the reason is that brimonidine can cause fatigue and sleepiness, drowsiness in young children. Even in adults, I had some adults complaining that they feel tired after we started them on Alphagan, and it's always safer to use aproclonidine rather than brimonidine. So how does it work? Well, alpha-2 agonists reduce aqueous production and increase uroscleral outflow. There was some reports a few years ago suggesting that they could increase contrast sensitivity. So they may have a slight neuroprotective effect, but that's not really been confirmed. The side effects of alpha agonists are conjunctival hyperemia, and they have a high rate of allergy, and I don't really like Alphagan for that reason. They have about 20% allergy rate. So usually Alphagan is last line for me. And it can cause fatigue, especially in younger people, as we mentioned. So next question about beta blockers. The correct answer is B. Okay. They increase cholesterol, they reduce HDL. They don't stimulate cyclic AMP, they inhibit cyclic AMP in the ciliary epithelium. So sorry, a bit cheeky question. So beta blockers inhibit cyclic AMP in the ciliary epithelium and reduce aqueous production. About 10% of patients don't respond to beta blockers, they're classed as non-responders. If patients are on a systemic beta blocker, then they have reduced effect with topical beta blocker, and that's because the systemic beta blocker is already having some effect on the intraocular pressure. A few years ago, people showed that if you were taking an oral beta blocker, which is a very popular treatment for systemic hypertension, then it was equivalent to using eye drops for glaucoma. So it's worth asking about that if you start a patient on a systemic beta blocker. Tachyphylaxis, meaning tolerance with prolonged use, can occur. And sometimes what you can do is you can stop the beta blocker if you suspect they're developing tachyphylaxis, and you can restart it again in a few months later, and you can overcome some of it. Bitoxyl is selective, so it has slightly less effect on bronchospasm and so on, but is less potent than timolol. And the side effects of beta blockers, I'm sure you're familiar with: lethargy, bradycardia. I've had 80-year-old men coming up to me complaining about their relationship with their wives after starting beta blockers, and that's not something that I was aware of, but it can have an effect on libido. And it can alter serum lipids, so it tends to increase cholesterol but reduce the high-density lipoprotein. High-density lipoprotein is, of course, the good cholesterol. Okay, so moving on to some surgical treatment. Regarding antimetabolites, which of the following is most true? Interesting. Okay, so the correct answer is increase the risk of endophthalmitis. So I'll just explain why. Antimetabolites have been used to prevent proliferative vitreoretinopathy, and 5-FU, I remember the study in the 90s which showed that 5-FU in the infusion bottle helped prevent PVR. But they did a bigger study later on, and it shows that there's no additional benefit from using 5-FU in preventing PVR. So most people are not using it. Antimetabolites does increase the risk of endophthalmitis because of the thin cystic blebs that you get, which can result in infection. 5-FU and MMC inhibit DNA synthesis, not RNA synthesis. MMC is associated with a higher incidence of wound leak. Okay, so when we increase our MMC use in the last 10-20 years, that's led to increases in incidence of wound leaks and cystic blebs. 5-FU, though, is more toxic to the cornea than MMC. And that's one reason I'm not a big fan of 5-FU. I remember as a resident in Moorfields, consultants were giving 5-FU injections weekly to patients who had trabeculectomy to prevent scarring. But some of these patients came back with quite nasty corneal epitheliopathy, which would take weeks to heal. So 5-FU is more toxic to the cornea. So of course we use these antimetabolites primarily in trabeculectomy, and the indications for trabeculectomy are when the pressure's not low enough on medical treatment. Virtually you can do trabeculectomy for any type of glaucoma, apart from aphakic glaucoma and active neovascular glaucoma. But other types of glaucoma is a reasonable option. The steps of the surgery, I'm sure you're familiar with, involve placing a corneal traction suture, conjunctival peritomy, and making a scleral flap. I usually make the flap sutures quite tight, and I can release them later. And some people like to leave them a bit loose, in which case you can anticipate hypotony and might have to deal with that in the first post-operative day. Conjunctival closure is one of the most difficult steps of the surgery because it has to be very tight. So next question's about aqueous drainage devices or glaucoma tubes. So which of these is true about glaucoma drainage devices? Okay, so we've had the number of votes drop to 14, so some people are falling asleep. Okay, so everyone voted B, and that's the correct answer actually. So corneal decompensation is a known complication, and you might be able to reduce that complication by putting the tube more posteriorly, either in the sulcus or the pars plana, but patients should be warned, and especially if they have corneal guttata or reduced endothelial function or count, you should tell them that there is a risk of endothelial decompensation later. You might be aware that the CyPass device, which is a new mixed device, which is not a tube as such, but a mixed procedure, it was withdrawn because of the safety concerns on the corneal endothelial counts. The glaucoma drainage devices usually contain a silicone tube attached to a silicone plate. None of them have a metal plate. Maltino's tube does not contain a valve. It's a non-valved tube, and you're more likely to get hypotony with non-valved tubes rather than valved. The Crawford is just made up. It's used in lacrimal surgery. I think it's not a glaucoma drainage device. So the indications for glaucoma devices are any glaucoma which is going to respond poorly to trabeculectomy or has failed trabeculectomy. And as you know, broadly speaking, if you're asked in your exam, you can start with the classification of valved and non-valved. Valve procedures are very common here in Saudi Arabia. Usually we use the Ahmed valve, which is a usually safe implant. The problems with the Ahmed valve are they can get encapsulated and they can fail, especially in children. And so the non-valved implants are a useful option in patients who have failed valved implants previously or in young people. You should be aware of some complications of glaucoma drainage devices. These can be during the surgery or afterwards. So during the surgery, you can perforate the sclera when you're fixing the plate. It's quite uncommon, but it's a possible complication. Suprachoroidal hemorrhage can occur with any glaucoma or any intraocular surgery, and you can minimize that by any sudden decompression of the eye intraoperatively. If you have a very low pressure or big hole in the eye, that will predispose you to get a choroidal hemorrhage. Post-operatively, you can divide the complication into two early and late. Early complications are hypotony, choroidal hemorrhage, usually occurring the first couple of days after surgery. Endophthalmitis can actually occur at any time after glaucoma drainage device. You can have early endophthalmitis because of the intraocular surgery, which usually presents in the first 2-3 weeks after the surgery. And then you can have late endophthalmitis due to exposure of the implant, usually. The implant can block, it can fail, and late complications of glaucoma drainage devices are tube exposure. Diplopia is uncommon with valved procedures and more common with non-valved. And the reason is the non-valved glaucoma drainage device, the plate rests underneath the rectus muscles, and because of that it can pull on the muscles and cause disturbances in extraocular motility. So the next question is about a 58-year-old gentleman who presents one day after trabeculectomy with a shallow anterior chamber. And this is a very common question in the R3, R4 exam. Okay, and you've probably talked to residents who've already done the exam, and they will tell you this is a very common topic, because you can go off at any cause of shallow anterior chamber, and you have to know all the causes and how to manage them. Okay, so there are about 10 people who have not voted.
Only 3 votes.
Let's get them up to 20, the number of votes 20.
Can we see the choice?
So, okay.
No enough thinking.
Okay, the correct answer is pupil block should be excluded. So just to explain why the others are not correct, the most common cause is not aqueous misdirection. It's an important cause, but not the most common cause. Aqueous misdirection is quite rare, but in Saudi Arabia we see it quite a lot because of the small eyes. And short axial length is a risk factor for aqueous misdirection. So we see it more here. I'd hardly seen any aqueous misdirection, maybe 2 or 3 cases before I came here. Any leak should be immediately sutured. Not necessarily, it's a very small leak. Sometimes you have a very small leak where you just pass your suture into the conjunctiva and you have a tiny suture tract leak. The anterior chamber is deep. Well, you can wait a few days. You don't need to go and suture immediately. But if the anterior chamber is flat, then yes. If you have a large leak, you need to go back and suture. Pupil block should be excluded. Some people don't do PIs for trabeculectomy, especially in pseudophakic eyes. But in here, I would not recommend not doing PIs because the eyes are short, you can get pupil block. Sometimes the iris can go and block the ostium. So always worth checking. It's an easy thing to do. Just check the op node, check the eye, is there a patent PI? And sometimes a PI is being done, but it's not full thickness. So these are things to make sure. And of course, if there's pupil block, you will see iris bombing. The AC should be reformed immediately. Again, if there is no, if the AC is shallow but there's a small leak, you can wait. You don't have to intervene straight away. But in eyes where the anterior chamber is getting flat and the patient is phakic, then I would intervene. Then I would reform the anterior chamber. The reason is the patient will get a cataract. Okay, having hypotony is the best way to get a cataract. Okay. And any patient having trabeculectomy who's phakic, you should warn them about the risk of cataract, because they almost certainly will get one. Topical steroids should be increased. Well, if they've got large choroidal effusions, it's reasonable to increase steroids, but some people would actually cut back on steroids if there's a leak to help the scarring response and help a leak heal. So how to manage a flat anterior chamber after trabeculectomy? Well, standard things you say in the exam. I will check the visual acuity, check for leak, and the intraocular pressure. Have a look at the bleb. Is it big? And sometimes you won't see a bleb if the pressure is low, but usually in the first few days post-op, you will see a large overdraining bleb, or you might see a leak. You're looking at the lens status of the patient. Are they phakic? Are they pseudophakic? Because this is going to influence your need for intervention later. Are they choroidal effusions? Okay, if the pressure is low and there's no choroidal effusions, I'm more relaxed. But if they have nearly kissing choroidals, then I'm not relaxed. Then I need to do something, okay? Because if they have kissing choroidals, then the VR surgeons are going to get involved and it's going to get messy, okay? Never get VR surgeons involved. So if the choroidals are big, it's better you reform the AC, you suture any leak, and then things will settle down and the VR surgeon can go home. If you've got an overdraining bleb, you can observe that, especially if the anterior chamber is deep. I had a patient, a fellow did a couple of weeks ago, pressure was 5, anterior chamber was deep, nice big bleb. I just left them alone. The scarring response over the next 2 or 3 weeks means that the bleb will get less and the pressure will come up slightly. And you've always got the option of cutting back on steroid drops. Number 1, look for PI, look for pupil block. If there's no PI, do a PI. It's the easiest thing you can do. Everyone should really be doing a PI, but in pseudophakic eyes, okay, it's reasonable not to do one sometimes. And I had one surgeon who never used to do PI in pseudophakic eyes because he got an 8-ball high femur when he did a PI. So that was his rationale for not doing PIs. But I think in the eyes here, it's always worth doing one, especially because they might go into aqueous misdirection later on. There's a high risk of aqueous misdirection here. And if you've got a PI already, then you know it's not pupil block and you can confirm the diagnosis of aqueous misdirection. Now, if you're suspecting aqueous misdirection, stick to simple things first. Okay, atropine. Number 1 treatment, atropine. Okay, in the exam, don't say I would do a YAG hyalodotomy first. Say I would give them atropine. Okay, the simple thing. And I have seen a number of patients who've settled just with atropine without needing any other treatment. There's a lady who came to us about a month ago, had simultaneous bilateral aqueous misdirection. And we gave her atropine, and 2-3 weeks later, her anterior chamber was deep and her pressure was normal. So simple things first. If atropine doesn't help, okay, you can do a YAG hyalodotomy. So how do you do that? Well, you can do a capsulotomy if the patient's pseudophakic, and you can do a few shots into the anterior vitreous with the YAG laser. Or if the patient has a PI, you can do it through the PI. And sometimes I've been asked that in the exam as well. Candidates have said, I would do a YAG hyalodotomy. How are you going to do a YAG hyalodotomy? So if you say something, make sure you can back it up. And they say, okay, a patient's phakic, how are you going to do it now? So you can do it through the PI. Okay, and if it doesn't settle, then you might be looking at pars planar vitrectomy. Now, the other cause of a flat anterior chamber, 1 day post-op, is suprachoroidal hemorrhage. Okay, again, that's easy to rule out. So if you do a fundal examination, you should be able to spot that. If you can't examine to the periphery or the pupil's small for whatever reason, then get a B scan. If they've had aqueous misdirection, I'll give a lifelong atropine. So from your examination, you can rule out all the other causes. Remember, aqueous misdirection is a diagnosis of exclusion. It's not the first thing you say. First thing you say is, I would look for PI. I would examine the fundus. Okay? Once if the examiner says, okay, these are all normal, and you say, okay, now I'm thinking about aqueous misdirection. So we'll give you a copy of this later, so don't worry. And those of you that were here last year might have this already. So in terms of early post-op complications, if they have, the first thing is, do they have high pressure or low pressure? Now, if they have low pressure and a flat AC, you're thinking about overfiltering bleb, you're thinking about a leak. But if they have high or normal pressure, then you're thinking about choroidal hemorrhage and you're thinking about aqueous misdirection. Now, classically, the books will tell you suprachoroidal hemorrhage, you have high pressure. What often happens is, I've had a couple of patients who had severe hypotony on the first day. The pressure was very low. Then they get their choroidal hemorrhage, so the pressure is 0. They get choroidal hemorrhage, then the pressure goes up to 15. Okay? Now the pressure is normal, but it's because they're a hypotenuse eye and they had a choroidal hemorrhage. So I had one resident who called a fellow, and pressure was 0 on the first day, 15 on the second day, and the fellow was informed, and the fellow was told the patient is in severe pain, okay, but when he found out the pressure was 15, he was relaxed. He said, okay, pressure's 15, it's okay, this is good. But what he should have been thinking is, well, why was the pressure 0 yesterday and why is it 15 today? And why is the patient in severe pain? And I knew, without looking at the patient, they had a choroidal hemorrhage. Okay, so next question. Okay, so have a look at the picture. Okay, so the correct answer is in fact C. Now, conjunctival swab is a useful thing to do because it's easy to do. And if you've got a rare organism, sometimes you'll pick it up on the swab. But actually, the organisms you isolate on a swab are often very different to the causal organism because you'll get contaminants. Okay? So although it's a quick, easy thing to do, it's not always accurate. So that's why I haven't said that conjunctival swab is vital. Some people don't do it, but I think I usually do it because it's a quick thing to do. And if you don't do it, then you've missed the opportunity, right? Once you start the patient antibiotics, you can't do it later. So why not just do it? Fundal examination you must do because if the patient, this is of course blebitis, and the patient has blebitis, you need to examine the vitreous and the fundus to rule out endophthalmitis. Again, this is a popular exam question. Blebitis, bleb-related endophthalmitis almost certainly come up in your exam. If you haven't revised this, don't go to the exam. Okay, it's easy marks. It's really easy marks. You know, if you've learnt it, you know, the examiner knows you know it. Okay, he's sitting there getting bored, drinking his tea. You know, you got full marks. So, what are the risk factors for blebitis? So, when you say you're going to take a history from the patient, okay, be specific. What are you going to look for in your history? You know, with the exam, I can tell you, it's been really interesting after being, you know, a resident and fellow all these years and now suddenly becoming an examiner. And you really, all the things you worry about as a student actually is never going through the examiner's head. You know, I'm thinking, okay, there's an hour left till lunch. How many we got left? Okay. Okay. Now you come in and, you know, we show you the picture, you keep talking, and we're like, okay, this is good. I'm going to get to my lunch soon, right? But you get, you know, I remember one of the consultants asked me, I had an appraisal with him after my corneal attachment, Stephen Tuft, who's just retiring now. And he said, Rich, yeah, you're really good, you know, but the fact that someone's grandma had jaundice in 1976 might not be important, you know. And it just shows that, you know, I was too detailed about things. So when you take your history, what are you looking for? Okay, I'm going to take a history. I'm going to ask about risk factors for this condition. I want to know, have they had trabeculectomy? Was antimetabolites used? Do they have a history of lid disease? So do they have a history of blocked nasolacrimal duct? So the examiner knows, okay, you're thinking along the right lines. And in casualty, you know that, you know, you have a limited amount of time. Okay, you haven't got an hour to waste on history. Often taking the history while you're examining the patient. So be focused on what you're saying. And if you don't focus on the right things, then you're going to waste your time. You know, you're going to spend 20 minutes talking about things that aren't relevant, and you've only got 5 minutes to talk about things that are relevant, and by that time the examiner's asleep. Okay? So the most important thing, you're going to examine the patient. I want to examine the patient to distinguish whether it's blebitis or bleb-related endophthalmitis. Bang. Examiner knows you know what you're doing. And how are you going to do that? You're going to check the vitreous, you're going to do a fundal examination, you're going to do a B-scan if you need. Yes?
Yes.
So the signs of blebitis include red eye, anterior chamber reaction, sometimes hypopion. Look at the bleb, is it turbid? As you know, we get the classic white on red appearance. The pressure can be low or normal. If they've had a leak, usually these patients will have a thin, sweaty bleb. okay, or they'll have a leaking bleb, so the pressure might be low. It might also be low because they've got an anterior chamber reaction and they've got uveitis, so the pressure might be low. Do a fundal examination and B scan is very important. The most common organisms, in fact, staph, followed by strep and Haemophila influenzae. Conjunctival swab, like I said, is worth doing, but it's not diagnostic. Okay, so if you get a positive result, look at it in context. Does it fit with the type of infection? Moorfields, our protocol used to be to put povidone in the conjunctival sac, okay, and that can help disinfect the conjunctival sac. So I don't know whether it helps, but it's a quick and easy thing to do. Start the patient on topical antibiotics. If it's just blebitis, we're talking about here, just blebitis. And later on, not immediately, but after 48 hours, if you start seeing an improvement, you can commence topical steroids. I usually start them on, if I'm not sure, I usually start them on 0.5% prednisolone. You don't have to start Pred 40 straight away. You can start low frequency, low dose. Make sure, if you've got some unusual infection, you could worsen it. So that's the rationale for using low dose steroids. We used to give oral moxiflox 400 milligrams, and the role of oral fluoroquinolones is a bit controversial, but I think a lot of people do use them, and it can be very effective. You have to check liver function before you start moxifloxacin. Okay, so anyway, I'll give you the answer here. But so this is an OCT picture showing chorioretinal folds. And chorioretinal folds, there are a number of causes for, and one of them, the most common cause we see in the glaucoma service is hypotony. Okay, so and this can persist, and it can lead to fixed retinal folds if left for a number of months. Now, the most common cause in our service is leaking or overfiltering bleb causing hypotony. And sometimes the chorioretinal folds may not be obvious clinically and maybe usually more apparent on the OCT. There are other causes of chorioretinal folds such as uveitis and posterior scleritis. So just bear those in mind. And again, management of hypotony is a fairly reasonable thing to ask you in the exam. So this is from the bleb-related endophthalmitis. Okay, so next bit about laser treatment. I'm sure you've all done PIs in the emergency room. So which is the appropriate power setting for doing PI? Okay, and I think we've already... So in non-pigmented eyes, I remember, as a resident, some people used to start with 1 to 2 megajoules, but in the eyes that we have here with very thick irides, I wouldn't bother with less than 3. And sometimes you need 5 to 7 megajoules to get a patent PI. So again, you could be asked about PI. How would you do a PI? And I'm sure you've all done one, so it's just recording the steps. So pre-medicate with pilocarpine and iopidine. Apply standard laser precautions. I think that's always good to say, so the examiner knows you're considering safety. I would lock the laser room door. I would have the sign outside, because that's what we do. Use Abraham iridotomy lens. Aim for a crypt, and usually just with a few shots you can get through. The endpoints you expect to see are deepening of the anterior chamber and pigment gush. Afterwards, it's worthwhile giving iopidine and checking the pressure in an hour, because they can get a pressure spike. Have you all done PIs? So PI, the indications are any primary or secondary cause of angle closure, and the aim is to restore the aqueous flow from the posterior to the anterior chamber. When you consent a patient for PI, you should inform them of the risks, such as IOP spike. And if you've got someone with end-stage glaucoma and they're having a PI, a pressure rise could wipe out the remaining nerve. So if they have a pressure spike to 50 and they haven't got much vision, then that could be serious. So you need to counsel the patient about that and also monitor the patient. And sometimes I've admitted patients who had IOP spike after PI. You can get transient corneal edema, and I remember there was a resident with me, of course I was only a resident a couple of years ago, but no, I'm joking, longer than that. But about 10 years ago, there was a resident with me who used a lot of power to do a PI, and the cornea decompensated. And this patient was a lawyer. So this is a nightmare. So always be laser. It can be very damaging, and you can hit the endothelium. Especially if the anterior chamber is shallow and the patient's got an acute attack, you can hit the endothelium quite easily. One of the other things you should warn the patients about is glare. Some patients who have a PI get quite bad glare, and these are often the type A personalities, who notice every little thing, and this can be disabling for those patients. And I was always taught to have a PI done at 12 o'clock underneath the eyelid to minimize the risk of glare, but I think the recent studies haven't really shown that a temporal PI causes more glare than a superior PI. So the next question is about SLT laser. So SLT stands for selective laser trabeculoplasty. Okay, so it may be more cost effective than drops. And that, I'm impressive that you know that, because that's actually a recently published study. The LIGHT trial has shown that SLT treatment can be more effective than lifelong use of drops, or even over a 3-year period that the study was done over. Doing a session or 2 sessions of SLT can provide the same IOP control and be cheaper. We don't use it in angle closure typically, but if you do a PI and the angle opens up, Dr. Jasim has some experience with that, and if the angle opens up, SLT can be effective later on. But I wouldn't use it as, say that in your exam, that SLT you would use in angle closure. Every procedure has side effects, of course. I think in view of the LIGHT trial, the SLT usage is going to go up. And I notice here in Saudi Arabia, people are becoming more knowledgeable and more aware of budget issues. So if you're working in the government sector or even in private, and your manager says to you, well, you can do one laser treatment, right? And it's much cheaper than giving the patient drops, so why don't we do that? So I think this is something that we have to be aware of. So SLT is indicated in open angle glaucoma. It's used as adjunctive treatment, so usually when the patient's on drops and you're not getting maximum control. It's very useful in patients who are allergic to drops. So if patients are allergic to drops, but their glaucoma does not warrant surgery, then SLT can be a reasonable first thing to try. And I think with time we're going to see more use of SLT as a primary treatment instead of drops. And that's the citation to the LIGHT trial if you're interested in reading that. Now, how many of you have seen or done SLT? So how do you do SLT? I think this is not a question that you'll be asked in the oral exam. There might be questions about it in the written. So I usually pre-medicate with pilocarpine. Some people don't use pilocarpine, but it helps open up the angle and improve your view. You give iopidine. Again, standard laser precautions. The lens we use for SLT is the Latina lens. It's like a large Goldman lens. And the typical powers we start at 0.7, 0.8. And the end point is we see bubbles. And if you see bubbles, most people will reduce the power. Again, afterwards, it's important to check the pressure, and usually we'll give iopidine afterwards as well. Okay, so this is a question about diode CPC. So in which of these scenarios is CPC most appropriate? We use a lot of CPC here. Okay, so generally we would not use CPC in eyes with good vision, okay, unless you're using it as a temporizing measure. So if you're doing CPC in eye with good vision, maybe, I'm going on leave tomorrow and I don't want to do a tube in case the patient has a flat anterior chamber, or the parents live far away and the child needs some treatment to bring their pressure down. So if you're considering temporary treatment, it's reasonable in eyes with good vision, gentle treatment, but otherwise generally we would not use it. So in a 56-year-old male patient with a visual acuity 20/100, so vision is good, okay, patient with failed trab, more reasonable option would be a tube. As a primary surgery in congenital glaucoma, we wouldn't use it unless the vision was bad, or we were sure there was no vision. In children, in very young children, it's very difficult to know what their vision is. So doing primary CPCs is unreasonable because once you do one CPC, two CPCs, then your options are limited later on. In a patient who had a blind, painful eye for the last 5 years, if you're treating pain and the eye is blind, start them on Pred 40 and atropine. Okay? And if the eye is still painful, then you can consider retrobulbar alcohol injection. Okay? The problem with CPC is there's a risk of sympathetic ophthalmia. It's rare. But if you tell a patient who's blind in one eye that, look, there's a risk of sympathetic ophthalmia, would they want CPC? No, they wouldn't want anything going wrong with their good eye. So I think this is a risk we often omit. The risk is very rare, but it's still there. So I think in an elderly patient, I use it in elderly people a lot because, if I do a filtering procedure, a tube on them, they're going to need multiple visits to the hospital. If anything goes on, I'm going to ruin their life towards the end of their life. So in elderly people with poor vision, I think CPC is a very reasonable option. So just a little bit about CPC. It's indicated in refractory cases or patients with poor vision. If the eye is blind already, please try Pred 40 atropine and refer them for retrobulbar injection. So in the exam, I know the guys at the university, they hate CPC. So if there's Salih or Bidan, sitting there, don't mention CPC unless you're absolutely sure it's a reasonable choice. The typical powers are used 1,500 milliwatts at 1,500 milliseconds. So if you have an idea about the settings, I think it's useful. It shows that you've seen a procedure before. CPC is not without side effects. Okay, it's a painful procedure. You can't do it under topical anesthesia. Most people will give retrobulbar or peribulbar. Sometimes you can get away with subtenon's anesthesia, but generally peribulbar or retrobulbar is preferred. There's a patient who had CPC here a few weeks ago and turned up to the corneal surgery with microbial keratitis to their only eye. So, corneal burn and secondary infection is a risk. So you have to keep the eye well lubricated both before and after the procedure. Particularly young people don't respond terribly well to CPC. And often you find even if the pressure is low initially, the pressure will go up in 2-3 months later and they need a second procedure. We had a few cases where CPC caused hypotony and retinal detachment. It's rare, but it can happen. And if you have a patient who had CPC and has unexplained reduced visual acuity, a few weeks or months after the treatment, think about cystoid macular edema. Okay? It can occur. And phthisis can occur with repeated CPC, and sympathetic ophthalmia is rare. Thank you. I think that concludes our glaucoma review. I think we finished well on time, and we wish you all the best with your exams, and we'll be sending you